This is HealthCall Online, the place for extended versions of interviews you hear in our weekly radio broadcast, the HealthCall Radio Hour, now heard on stations around the country in national syndication. Back pain is one of the world's leading health complaints. It's a leading reason people see their doctors. It's also one of the leading reasons people are taking time off work away from their jobs. With all the concern about opioid addiction, the picture's changing a little bit. Doctors are far less eager to prescribe medications. So, does going to your family practice doc really help that much? Well, the advocates of the direct primary care model say their flexible, personalized form of medicine is a real advantage to patients when it comes to dealing with this type of problem, pain of all sorts. Let's learn more about that by talking to Dr. Jarrod Wiegman. He is the founder of Indiana Direct Primary Care, board certified in family medicine and internal medicine as well. So, hey, Doc, let's start with the basics here. And for people who don't know, give us the big picture on what makes direct primary care different.
So sure, direct primary care is a direct answer to some of the problems that exist in healthcare right now. And a lot of those problems are being able to get into your doctor, being able to contact your doctor or doctor's office, and having to deal with the insurance companies and deductibles that are rising. So what direct primary care does is that we have a very simple model. We charge a fee for service, or a monthly service, I should say. So it's a monthly fee where you come in, you get direct access to your physician, you get unlimited appointments, you have the ability to spend more time, meaning 30 to 60 minutes at that appointment. And we just have the ability to take on more than the regular primary care docs do these days, that when they only get 5 or 10 minutes, we are able to take on root cause problems of things when people come in. We're able to take on multiple diagnoses at a time. We don't limit people to 2 or 3 things when they come in. And that gives us an advantage and kind of reinstates that doctor-patient relationship that really should exist.
So tell me, when it comes to dealing with back pain and chronic pain, how does that flexibility and that personalized care make a difference?
So the first thing is figuring out why they have back pain. And some of that's already been done. Sometimes they've had imaging done. Sometimes they've had previous injuries that have occurred. But when we get to the root cause of why they have their pain, wherever that comes from, whether it be knee pain, back pain, whatever, we can address it in multiple different modalities. We don't have the restrictions where, spending a very short period of time where it's easier to write a prescription to send them out the door to cover pain. We oftentimes try to not just treat pain, but also try to figure out ways that we can make people more functional, ways that we can have them have less pain, ways that we can get them off medications. And that oftentimes includes, looking at their day-to-day life. What do they do day-to-day that we can adjust for them? What can we add to their services, whether that be, massage therapy, whether that be physical therapy, whether that be chiropractic therapy, all those other modalities, trying to add in to try to correct some of the underlying things that are going on. And then just from a day-to-day standpoint, being able to correct some of the things that further injure them or get them in those flares, so to speak, that they get to. If we can lessen those, that's huge.
So when do you prescribe medications, and how are those going to be used?
So medications oftentimes are used in the acute setting, obviously, when people have severe pain and they can't overcome that and get to some of those other modalities. When your back's spasming, it's really difficult to do anything. And the chiropractors will tell you the same thing. If you can go to the chiropractor, but if you have a severe muscle spasm, oftentimes they can't do much. So we may need to use medications in those respects, including, simple things like heating pads, topical rubs. Doesn't always just include pills. There are other options available to relieve those symptoms, so we can go further in their treatment with other modalities like chiropractic.
Understand. So I want to take you back to your training. Since back pain and muscle pain is such a big factor for people seeing their doctor, how much training do physicians receive about dealing with this problem? Is it adequate? Are they up to speed on the latest strategies and techniques?
So I think the new training methods are probably better than, honestly, when I went through training. When I went through training, we were literally in the time where pain was kind of added as a vital sign. and it was treated as a vital sign to a point where the opioid companies really pressed hard at moving people to the short acting and then onto the long acting opioids, and that sort of was the treatment plan for these people. It was said, we're not trying to fix anything, we're just trying to make their life better by treating them with pain medication. And so that was my training, literally. How do we get their
Wow.
pain down? What pill level do we have to sustain them at to get them functional? And what we realize now is that was a huge mistake.
Yeah, sure. Well, I think we do. That's pretty clear, right? We've all kind of seen the problems that's followed that. So now in your practice, what do you find is the leading cause? What brings people to you with pain? What is their source?
So it really just depends. I mean, probably 30 to 50% of the visits that we see in a primary care doctor's office, at some point during that visit, they're going to come up with some sort of musculoskeletal complaint. Sometimes it's something very simple. They tweak something, doing something, and they're taking a couple ibuprofen, and that helps, and it's no big deal. But oftentimes it's, as people get older, it's chronic knee or hip pain. Um,
Right.
Areas where they're not quite ready to do severe procedures like knee replacements, hip replacements, but maybe they've done an injection here or there, or maybe they've done some pain medicine here or there, but they've not really done anything to help from a functional standpoint. So a lot of what we do is, in our particular practice, we have a gym associated with it. We walk them over there and we show them how they can strengthen the muscles around the joints to really help protect them. We work on stretching, which is a huge thing for people, especially when they have that stiffness in the morning with just general osteoarthritis, or at the end of the day when they've overworked themselves. So there are those modalities that we can use here and move people along when they have those sort of more chronic complaints. The acute ones that are very short, those are sometimes easier to deal with, and sometimes medications, can quickly relieve that. But
Hmm.
most people that come in as you get older are going to have more chronic complaints, and those are the things we really want to tackle.
Yeah. So just on the point of medications, I think people are often confused. Is ibuprofen, acetaminophen, aspirin? What typically do you recommend? What seems to be most effective?
So it really depends on the injury. When we look at acute injuries that are very minor and we suspect that they're going to be short term, oftentimes we use anti-inflammatories. Those anti-inflammatories exist all across the board. There's a number of different varieties of them: ibuprofen, Advil, naproxen. Those sorts of things can work. Oftentimes there's a topical gel called Voltaren gel that can work really well as well. That's over the
Hmm.
counter. It's just a rub-on gel that's very similar. So those type of things for those initial injuries. When you look at just chronic osteoarthritis, the data really shows that the anti-inflammatories long term are really probably not best for those. Even though it's an inflammatory condition, the recommendation really is to start off with standard Tylenol daily. And we have to be careful with that because Tylenol is something you can overdo, but at the right doses, at a scheduled dose, people oftentimes, if you look at the studies, do better with just standard Tylenol scheduled 2 to 3 times a day than they do other medications.
Really? Yeah, I do know that acetaminophen toxicity for the liver is a concern, and particularly when you mix that with alcohol, that can be a big problem as well. So let's talk a little bit more about that joint pain as opposed to generalized muscle pain. So, A, work on strengthening the muscles around the joint, but then what? Or what in a typical direct primary care practice? What else can you do?
So strengthening is the first thing. Sometimes we do add medications or muscle rubs or kind of joint things. In our practice, we do some non-traditional things. We do essential oils. There's some great essential oils, including things like CBD oil and other things along that path that people are open to those concepts. There are other supplements that you can take over the counter, such as glucosamine chondroitin. Is a great supplement, well defined for people who have osteoarthritic joint problems. And then there's also injections. At some point people get to the point where doing injections of a kind of a local anesthetic and a low dose of a steroid can really help decrease the inflammation in those joints. That's one thing that you can't do often. You can do maybe a couple times a year, 3 times a year, but if it provides people that ability to do what they want to do to lead that quality of life, to get them through to a point where they may have to have surgery or something more significant, that is something we can do here to kind of prolong their joint life.
And that comes at no additional cost as part of your overall inclusive model, right?
Correct. So basically, any procedures that we do here are essentially included in the monthly fee. The medicines associated with those procedures, in this particular case, when you look at the steroid, it costs around $15 for that particular medicine. But most places that you'd go to will charge $200-300 for that same joint injection. So
Yeah, that's a huge savings. I'm kind of surprised to hear the essential oils and CBD. I'd like to hear more about your experience with that and how that really works for people. Because I'm kind of a skeptic on that, frankly.
I really was too. I was not trained in sort of what we'd call non-traditional, medicine such as those things. But what I've found is everyone in our office uses these same things for different purposes. Obviously, I don't have severe osteoarthritis. However, everybody's had an injury where they've had pain or something happen to them. So we've all tried it. Using these rubs and oils and even some of the supplements such as glucosamine and chondroitin are personal trainer nutritionist. He's 62 years old. He uses that daily now, and we all find benefit to those things. So it's really not a matter of we think it works. It's a matter of we've used it and we know it helps.
So if I am suffering from that osteoarthritis and that's the source of my pain, how can you help me through that?
So again, a lot of different modalities there. It's strengthening, it's using whatever people are comfortable with. So I would argue that if people are comfortable with things like CBD oil, that is a very effective pain control. There are also non-CBDs essential oils. There's an essential oil called Deep Blue that's got a variety of mixtures of things that also can help. Again, the mainstay of treatment for people who have severe osteoarthritis and need a medication is oftentimes Tylenol. So routine scheduled Tylenol throughout the day. And then beyond that, I talk to patients about whether or not, how bad their joint is, whether or not they would be open to injections. And at some point, there's going to be a need for an orthopedic referral for people as their joints just become, broken down and there are other reasons too. It's not just osteoarthritis. People have knee injuries where they have meniscal injuries or ligament injuries and things like that need to be taken care of from a surgical standpoint too, where they just need to be cleaned up a little bit. Those can be quick procedures, but again, we try to put those off to the very end because obviously with any procedure, there's a risk.
Sure. Yeah, I get that. So when do I need to be seeing my doctor about pain? Do they wait too late or do they go too soon?
So it just really depends. Everybody's different. I think when it affects your quality of life, when it affects your ability to do what you want to do in your daily routine, that's the time to go talk about it. Everybody's pain tolerance is different. I'll see people come in here that don't look like they have severe arthritis on their X-rays, but they oftentimes complain of severe pain associated with what sounds like arthritis. But I've also seen patients come in that are 80 years old that literally are bone on bone and they don't complain at all. Why
Hmm.
that is, I don't know. I don't know the answer to that. Everybody's, like I said, pain tolerance is different, and everybody's ability to and how they react to pain is different. So come in when it's affecting your life.
Do I, how do you talk to people about pain? What are the questions that you ask to try and get a sense for how you feel this pain and experience this pain?
So oftentimes, we start with the general, what is your pain level? Looking at that, and it tells us, gives us an idea, where they feel like their pain is. So, if they're sitting at a 9 or 10 and that's severe pain to them, then that might lead us down a different route of treatment and plan. If they say they're playing, hey doc, it bothers me, but it's really only a 1 or 2, that would obviously lead us down other routes. And then it's describing the type of pain, obviously, how significant is the pain and what's it feel like to you. And then the last question, and maybe the most important, is what is it preventing you from doing? What
Hmm.
in your daily routine can you not do that you want to do because you're experiencing this pain?
Do you know how many direct primary care practices are associated with the fitness center? I know you have a gym in your facility and a trainer on staff. Is that fairly common?
Pretty uncommon, actually. I don't know of any other direct primary care physician or physician's office that has a gym literally located in the office. I know there are some direct primary care facilities that really do push this, model that really will go above and beyond and do fitness classes with their members. Will rent out fitness facilities. Will do walks with the doctor, walks with the nurse practitioner, do other in Indiana, in Fort Wayne, Indiana, we have the Fort for Fitness things where we sponsor events out there and actually go out there with our members. So there are other places that do similar things to that. None that I know of that physically have a gym located with them.
In the direct primary care model, typically I have access to you all the time, right? I've got your cell phone number. I can text you, video conference, all those things. That's one of the advantages I've seen described for the direct primary care model. Who really in the pain world is going to benefit most from this?
So I think everybody, for the most part, because when you get to a point where if you are on medication therapy and you need refills, if you're on essential oils and you need access to those, being able to contact the doctor directly to be able to get those very quickly is important. Being able to talk about those increases or flares of pain. What can we do to address those quickly? Because the quicker we address them, the more likely people are to get back to their functional status and what they're missing out on. So, an injury at work, for instance, they need, or an injury that doesn't happen at work or that prevents them from going to work, whatever we can do to get them back to work faster. Everybody, that's not independently rich needs a paycheck and needs to be at work.
Yeah, there's a benefit to getting back on the job and getting back to life. I agree. So if I have to go for imaging and that kind of thing that's outside the cost that I'm paying you for my subscription, my membership fee, how is that handled? And is that then channeled? Is there some discount arrangement? How does it typically work in the direct primary care model?
So yeah, most direct primary care practices will have contracts with independent imaging places that exist around their towns, independent laboratories the same way. So you'd be surprised at what kind of pricing you can actually get for certain things. For instance, an X-ray, here in Fort Wayne, Indiana, at the independent practice, runs about $95. That's with the X-ray and the read from the radiologist. There's not two separate bills there. Where in a normal insurance that might run $300 to $500, and depending on the market you're in, that may be a little bit higher, a little bit lower. What you'd get for that, but every direct primary care practice tends to have these independent contracts to help those that don't have insurance. But I will also say that some of our members do have insurance. They just have either really high deductibles or just can't and don't want to maneuver the regular health system anymore. They don't want to spend 5 minutes with their doctor. They don't want to wait 2 weeks for an appointment. They'd rather do this model and have their insurance. And in those cases, they could use that insurance at any imaging facility that they choose.
Sure, that makes sense. So if I'm an employer and I have the type of business where I've got employees who are missing time because of either work-related or other injuries, I just have people that tend to be out of the job a lot. What role is there for direct primary care?
So there could potentially be a huge role there. There are companies that actually have, company-related clinics where they have their own doctor for purposes like this. But for other small businesses specifically who have a hard time being able to provide insurance for their, employees, or they have pretty high deductible plans. Getting them into seeing the doctor can be difficult sometimes because of the extra cost out of their pocket, and then also the time frame in which they have. Most people work during the day, and most doctors' offices are open during the day. So they
Right.
either have to leave work or they're off work for those appointments. In the direct primary care model, we can do, non-traditional appointment times, weekends, after hours, and we can get people in pretty quickly too. So if people need to leave work for something, rather than being gone a half a day for a 5 or 10 minute appointment, they're literally gone for their 30 minutes to an hour, whatever they need, and then they're back to work.
Yeah, that's a real cost advantage in a lot of ways. Tell me about your experience now. I mean, you've got a background in traditional medicine. I understand you're a hospitalist and have been in the corporate medical world. What's it mean to you being in this direct primary care model? How has that changed the way you care with patients?
So it doesn't change necessarily the way I care for patients. It changes the time frame in which I'm able to do it. I'm able to spend more time with the patients. I'm able to do everything that I want to be able to do and everything I thought being a physician and having that patient relationship would be. I'll be honest, part of the reason I'm a hospitalist and did a lot of hospital work was because in that particular setting, there are no time frames. If I need to spend an hour with a patient in the hospital, I can, and there's no limits to that. So I have oftentimes chosen my career to uh, go towards and gravitate towards those areas where I can spend more time with patients. But I've also, at the same time, been in some of the other models where you're literally rushed through, you're trying to see as many patients as possible, you're trying to get people in and out the door. And what that leads to is just poor medicine, to be honest. There are certain things you can't address. There are certain things I want to do that I can't, and it's very frustrating for not just the patient, but also times the providers too.
Well, I will include a link in the show notes to a directory of direct primary care offices around the country. So if you're interested and you want to find out, is there a physician offering this type of service in your area, you can find it there. Anything you want to leave us with, Doctor, before we cut you loose?
Yeah, I mean, I think that the healthcare system that we have has a lot of difficulties, and I think that we need to research and find new ways to do things to help patients navigate the system, but also recognize that the system is broken the way it is, and we need to care for people and do more preventative medicine now more than ever. And I think the direct primary care model allows us to do that. It gives access for patients to do that, and I think the more patients understand and realize it exists out there, the more this is really going to grow.
Well, that is Dr. Jarrod Wiegman. He is the founder of Indiana Direct Primary Care. You can find them online at indianadirectprimarycare.com. Doctor, thanks.
Thank you.